Well, so I think that we can start this presentation. Oh, Chloe. Right. Fine.
I was supposed to be somewhere else, so that's why I wasn't here. But well, thank you, Massimo, for coming. As you know, Massimo Cardillo is the director of a big country for Europe, which is Italy, from the National Competent Authority. That, as you have been seeing till now, they have to put in place the regulations, the allocation system, and they are a real support. And Italy is a really good example of an effective and efficient national competent authority. And I really want to thank you, Massimo, for sharing your experience. And the floor is yours to talk about DCD.
Thank you, Chloe, for this very kind presentation. And I realize that I am really the last barrier between you and the coffee break, so I will try to be very fast. And I will concentrate on the challenges and opportunities of developing a DCD program in the international setting, and especially in Italy, and what can be the opportunities also for the Indian program too. As you know, the DCD program was the starting point in transplantation activity in the early 50s, because transplantation started with living donors and with deceased donors with after cardiac death. Only after 1968, with the Harvard Commission started the program from DBD donors started. So it is now a return to the past. And as the WHO stated, the opportunity to develop DCD program is the possibility to really enlarge the donor pool. And as you see, in 2010, the WHO stated that the donation from deceased person as a consequence of death determined by neurological criteria or by circulatory criteria was affirmed as the priority source of organs to meet the very important demand of more than 100,000 people all over the world. Very recently, the Council of Europe issued a recommendation that was directed to all the governments of the member states in Europe to explore the opportunity to develop the DCD program, and especially the Commission gave indication to respect some very important principles, such as the independence of the decision related to the treatment option of patients from any consideration of organ donation, the criteria for determining death prior to the recovery of organs, and the ant and post-mortem intervention to improve the quality of organs for transplantation. So a set of rules, a set of recommendations that are really important for the member states in our countries. This European group, coordinated by the National Transplant Agency in Spain, Beatriz Dominguez Gil, organized a group of discussion and produced this document that was published in the Intensive Care Medicine Review in 2021, and underlined that health authorities, professional and professional association should evaluate the circumstances of patients dying in ICU. And in countries where the suspension of the futile treatments is an accepted practice, in consideration of this futility and end-of-life care, the possibility of developing a DCD program should be a routine component of end-of-life care. So the development of such program is really a kind of way to show what is the quality care in intensive care unit, and this group developed also an algorithm to define a pathway that comes from death assessment to organ procurement, both ways, in determination, after determination of death, with brain criteria and with circulatory criteria. So this program should not be considered as a single program, a program alone, but always be combined with the possibility to have DBD donation. So the other very important principle to respect, that DCD program should not decrease the DBD donors, and this is a risk in some setting if the withdrawing of futile treatments happens too early, as for instance. And this is a new target for ICU personnel, a kind of social and professional responsibility for the future generation of intensivists. So this group in Europe developed a protocol, and this was offered to the scientific community in Europe to include this possibility to offer the donation programs after the determination of death. You know what is the situation in the international settings. The DCD programs are very differently planned and realized in different countries. You see they're very active in Spain and United Kingdom, and very little activity in other countries such as Italy. Another very important principle to respect in developing such programs is the fundamental respect of the dead donor rule. This is a very central ethical and legal challenge in developing DCD programs. So the determination of the timing of death for patients who die after the withdrawing of life-sustaining treatment is really crucial. This is very important because establishing ethical and legal standard is really important to affirm confidence also of professionals that work in intensive care units, and also to organize a correct relationship with the family that are asked for consent in these cases. It is very important that the removal of organs for transplantation must not precede the death of the organ donor. And the defining of the timing of death is so important, also because the duration of ischemia before organ recovery is closely related to the viability and the quality of transplantable organs. In some setting, this is a risk. In the UK model, in this paper, is showed that sometimes happens that the withdrawing of treatments is made too early, in consequence of probably a poor prognosis. And so this is a risk to shift from a possible DBD to a DCD donor. So we have a donor, but probably that donor should have been a DBD donor. You see that in Italy the situation is quite different, because the ICU days before death determination are longer. We have a mean of 3 days in the DBD settings and 8 days in the control DCD settings. That it is a longer time compared with the UK and with Canada. So in these cases, probably it is much easier to have a more correct prognosis that make possible the suspension of futile treatments. Sorry. What is the background in Italy? In Italy, the DCD programs suffered from self-exclusion, mostly due to the problem that we have a very long no-touch time of 20 minutes for death determination. And this was the main reason why in Italy the program started very late when compared with other countries. And we in the first times when we started with the program, probably very few people believed that that was possible to do with such a long no-touch period. But then we implemented some national end-of-life care recommendation, and there was a diffusion of the use of the abdominal regional perfusion and the widespread use of ex situ DCD organ perfusion that made the program possible to start. The law in Italy is very strict as concern the determination of death, because the law states that there is only one death, but there are two different ways of determining it. So the death is defined as the total irreversible loss of all the encephalic function, but death can be assessed with neurological criteria, so directly, and can be also assessed with circulatory criteria. And in this case, we need to have a 20 minutes continuous recording of absent electrocardiography activity. It is a very long period compared with other countries all around the world. I think that only in Russia there is a longer period. So one death, but two mechanisms. This is very clear for all professionals, because this law is 20 years old, and it is also very clear to make the family understand what we are doing. But nevertheless, it was no easy to start in the early 2000 with the DCD programs for poor compliance of the professional in intensive care units, the lack of political support, and the doubts about prognosis and the fear of litigation. So the same problems that we have discussed about in the Indian setting, as you know. So religious and legal misinterpretations too. In any case, we started in the early 2000 years. We started with the lung programs, so the lung procurement from uncontrolled DCD program. The program started in a special hospital in Milano, and it was possible for the availability of this ex vivo lung perfusion, that is a way to assess the lung functionality after retrieval. In the following years, we define a strategic program, and we issued a position paper for the determination of death with the cardiocirculatory criteria and the consequent development of a donation program, and with the aim to integrate the highest standard of care for the dying and legitimate the interests of those awaiting of life-saving organs. We also started a program of procuring organs from DBD donors that are rescued from cardiac arrest with an ECMO treatment. This program was started in San Raffaele Hospital in Milano, and we had a certain number of donors with this program too. We define a document to set what was the maximum warm ischemia time possible in the case of controlled donation, because every professional, every transplant professional was very concerned about the possibility to use this organ, considering this very long warm ischemia time connected to the death determination. But this document was very important to make them confident that this possibility can be proved. So we started the control DCD donation, and especially using the normothermic regional perfusion to maintain the organ function before retrieval, and that was defined as mandatory in Italy, because that was a way to help organ harvesting and considering this peculiarity of our death assessment. So the in situ normothermic regional perfusion was really the way in Italy to have this brilliant result. We defined also what were the invasive maneuver that was possible to be performed in the potential donor. There are differences in Italy compared with other countries. We can use heparin administration during the agonal period before the cardiac arrest. On the contrary, in United Kingdom this is forbidden. We cannot use early cannulation, because cannulation can be performed only after the death determination. So there are very peculiarities also in this case. In 2015, we had the first controlled DCD in Turin, and then the first liver transplant from DCD in Milan. And in the following years, the program really improved. Very recently, also other groups stated that the use of the regional normothermic regional perfusion is really important to improve the harvesting of organs from this kind of donors. Also in the case of different and more rapid way to determine the death with the circulatory criteria, because as you can see in this series, the harvesting of liver and kidneys from controlled DCD donors is better in the case of using normothermic regional perfusion when compared with the very fast harvesting without perfusion. So you procure more organs in this way. You see in Italy the procurement activity increased in the last years, and in 2022 about 9% of all used donors were from DCD donors. It is a very low percentage when compared with Spain or with the USA or with United Kingdom, but the program is really improving. Most donors are from more organs are from control donation, and so it is easier for us, but also some regions are active in uncontrolled donation too. In last year we improved of about 40% in potential donors and more than 60% in utilized donors, as you can see in this slide. Many regions are involved in this project, in this program, you see, and some are developing controlled donation, and some regions, both programs are active, and some regions are, just like Tuscany, are more involved in uncontrolled DCD donation. These are the numbers in the last 5 years. You see the different etiology of deceased patient. There is a difference in the organ harvesting when comparing controlled and uncontrolled DCD donation. You see that the percentage of organ transplanted is higher in the case of controlled donation when compared with uncontrolled. So under this point of view, this procedure is more effective in guaranteeing the use of organs. Also, you see that when organs are perfused ex situ, the percentage of transplantation increase. So this is also a way to improve the use of organs procured from this kind of donors. Last year we issued another document, a very important document. It is a consensus document that were issued by the National Transplant Center with more than 100 professionals involved in writing these documents on controlled DCD donation in Italy. It is a position paper with recommendation on 15 items with 5 chapters and 42 questions. The targets were defining principles and professional roles in this activity, defining the clinical context and the organizational criteria, and give indication for professional to how to improve again and more this program. And the principles that are expressed in and underlined in this position paper are that national recommendation for end-of-life care in ICU are mandatory, and the possibility of donating organ and tissue after death should be always offered as an integral part of end-of-life pathway. And also the decision that should be transparent and shared. The decision of suspending treatment should be independent from the donation option, and separate roles and responsibilities in end-of-life care, and separate roles and responsibilities also in organ preservation versus organ procurement. Thanks to this document, we started also a procurement program of abdominal and lung organs together. We defined also a protocol for harvesting, the multi-organ harvesting in the case of control donation. And very last, we are developing a program for harvesting also heart from these controlled donors. It is not easy in our setting, but I think that probably this will be possible if we define a very shared protocol, and also other countries have demonstrated that it's possible to harvest heart from controlled donors. So I think that it will be possible also in Italy. We have set up a national data set to collect all information about donors and about patients. This is very important to measure, to monitor the program, to have information and publish data for organ and transplant results. And as regards transplant results, you see that the outcome of the transplant performed with organs from DCD donors are very satisfactory. I go to directly to the survival curve. You see that in the case of kidney transplant, the 1 year graft survival in the case of controlled donation is quite comparable to DBD donors and higher compared with uncontrolled DCD donation. And also for the liver, the transplant results are very satisfactory, because we have 1 year graft survival of 90%, that is higher when compared with DBD donors, and higher also when compared with uncontrolled DCD donors. So we have very good results with these organs. We are developing education on DCD donation. We have a lot of courses and other initiatives to promote education among professionals. And also we have demonstrated that this controlled DCD donation is not only possible in very big hospitals such Milano or Rome, but we had DCD donors also in smallest hospitals such as Syracuse in Sicily, when we had the first donor retrieved in November 2018. So I think that if we believe in this program, in this possibility, everything can be possible to start. Thank you very much.
Can I ask?
Please.
You know, you said the notice time 20 minutes. That continues, hasn't changed.
Yes, we have no possibility to change this because we have discussed in the National Bioethical Committee, and we have tried to convince them that in every other country in the world the criteria are different, but there was no possibility to change because in Italy there is a strong position of some Catholic professionals that are very strict and very cautious in defining the time for that determination. So
one of the challenges we have when we talk about DCD countries is when there's no consensus from the medical professionals internationally, then they ask, when you guys don't have, you're not aligned in your thought process, how do you say that this is acceptable? So I think there has to be some consensus internationally, so because UK used to follow 5 minutes, 2 minutes, 10 minutes, 20 minutes with Italy. So that kind of sometimes makes the political support a little of discomfort. My just comment.
well, under a certain point of view, I think that in Italy we have less problems because since we have 20 minutes, nobody have doubt that people is really dead. But in any case, I think that it would be preferable that Italy should be ruled as the other country in the world. I don't know if this will be possible in the following years, but I think that in any case, also with the 20 minutes of no touch, we have shown that it is possible to have this transplant, and also with very good results. So
You also use normothermic perfusion quite frequently, I think.
we always use because
Cost goes up.
we always use the normothermic abdominal perfusion, and we always use also the XC2 perfusion machines.
Yeah. But not everybody uses that everywhere else, as far as I know.
Yes, I know. Yes, it is a matter of cost.
Yeah, exactly. I mean, that escalates the cost even in India quite a lot.
Well, but I think that in the future, with a more wide use of these technical tools, the prices will lower probably.
Yeah.
Yeah, I just wanted to understand, I mean, you have shown a couple of papers and as well as some case reports where you have successfully done DCD process. So I just wanted to know, were you ready with those perfusion equipments, for example, ECMO, perfusionist, the person who will cannulate, so all these things were preset in that particular setting, and you went ahead with the DCD process?
Well, we started in only in those places that were ready to have these facilities with the ECMO team and the professional that were skilled to do that, But in the time, many more hospitals were involved in this program. We have also a region that is Lombardy that has organized a regional ECMO team. So there are a bunch of professionals that are able to move from their hospital to another one when there is a possible controlled donation, and they go to that hospital and make the regional perfusion and to make harvesting of organs possible. So it is not only in the transplant hospital, but this donation is possible also in other hospitals in the region that is organized with a regional ECMO team.
So was there any cost-benefit analysis between controlled and uncontrolled DCD situation?
Well, I think that it is very different. I have no precise data, but I think that the future is in controlled donation, because uncontrolled is very expensive, time-consuming, and is very. It has a very deep impact on the organization of the hospital, and very few places are organized and have trained people to do that. In Italy, we have only one hospital that has a significant uncontrolled activity, that is in Florence, in Tuscany. And but they have a very strict protocol. They have been organized since 10 years ago in doing that. But it is not easy. It is not easy. Probably it is more cost effective to invest in controlled donation. If you have a good protocol in end-of-life procedure, because in controlled donation it is a matter of having a good protocol of end-of-life, have professional trained of approaching the family and displaying how end-of-life is managed. So there are different problems, not organizational, but of communication skills, and but I think that the future probably is in controlled donation.
But without any escalation of cost, additional cost?
Well, I don't think so. I don't think, but it is more an ethical problem than a problem of costs.
Regarding cost, if you perform DCD, you will shorten up the stage of the ICU. So you win less days, and you have some expenses for the normothermic or regional perfusion. Because at the end, at the very beginning, we used to do super rapid extraction, and the results were quite poor. So there are literature now that it says that it's better when you make normothermic or regional perfusion. And for example, in France, it's mandatory. You cannot start a protocol of DCD if you don't have this kind of resource. We don't have in our hospital. They have portable and they come to us. That's the point. Okay. Anyone comment? Okay. Okay. So you're hungry? Are you hungry? I am. Thank you, Dr. Cardillo.
Thank you.
Okay, that's for them to. Yeah. It's for them to talk. Sí. Okay. Okay. You read the first one. Okay. Yes, more people is coming. Sí. You can read if you want.
Should I start? A 35-year-old male is admitted to the hospital, diagnosed with acute meningitis. Neisseria meningitis was found both in cerebrospinal fluid and the blood culture, so a specific antibiotic therapy was started on a day 3 with vancomycin and meropenem The diagnosis of brain death was made on day 5. A second culture of blood and liquor were not yet available on day 5. The transplant coordinator totally rejects the patient as an organ donor due to the cause of death.
Okay, let's discuss then. These are the different options that we have. Only tissue could be used, but not corneas. The transplant coordinator is right. Neisseria could be transmitted with the transplant. Due to infective risk of the donor, organs could be used only in emergency cases, or all suitable organs can be used because the donor has been treated with a specific antibiotic. What do you think? Second. Let's say 1. How many? No one with 1. Okay. 2.
But the second result hasn't come yet.
No.
Culture of the second hasn't. The result of
Culture report is not available.
Yeah, but look at this. Look at this. How many days has been treated and well treated this patient? Come here with us, please.
You two come all near.
Yeah. On day 3, they start day 3 and we are day 5, so 48 hours. Good treatment. Only or enough? What do you think? It's not enough? For you it's not enough? For me it's enough. 48 hours good treatment in a meningitis situation. Just to think as a donor. Okay? Yes? So then, the second, transplant coordinator is right. Do you think he is right?
He's right that it could be transmitted, but you have the antibiotic that you're giving and the person, donor is responding, so you should give the same antibiotic to the recipient. And the culture will be ready by then. You can give it, you can straight away treat that person, put
Okay.
the lesion on the antibiotic.
Okay. It's not a septicemia it's a meningitis. It's different, right? So, which is the best for you? 4. Do you all agree? Yes? Okay, next. For us, 24 hours is enough. We used to wait 48, just in case. But if we have 24 hours, we will proceed. That can be different in different parts of the world, that's true. But every year we have 3, 4 meningitis that become organ donors. I don't know, in Portugal it's the same. We use them, okay? And it's safe for the recipient. You know which is the cause of the meningitis and you treat in the recipient if it's need. Right?
You must be convinced of this because you are the ones who are going to convince the other partners. Because the others will get suspicious and your job is to convince them that this is safe. Okay? So otherwise you lose the suitable donor.
Right? Okay. Next one.
Case 2, a 20-year-old with an incurable cranial traumatism is being treated in the ICU to permit recovery of various organs for transplantation purposes. Death has been certified by a team independent of the transplant surgeons. Authorization is given by some members of family while others object.
Right, we have a problem. No? And how we solve the problem. We have different options. The recovery of organs can be performed because some family members has given their consent. The organ recovery cannot be performed because some family members have not given their consent. It's necessary to continue the discussion with the family members and seek to establish the will of the deceased until the consensus for that is achieved. or family members do not have any right to permit or prohibit organ recovery. 3. Then you know how to do family approach, how you will solve that.
Give them time.
Very good.
Tell them to meet other organ donors and
Mhm.
recipients.
So you have different arguments to try to convince them. But the agreement has to be inside the family. If you don't achieve this agreement inside the family, sometimes it's better to lose a donor than to. Yes. Right? So, next one. Doesn't work?
A 7-year-old donor died of head trauma due to a road accident. The donor tests positive for anti-HCV in the absence of other abnormalities. The transplant coordinator offers the liver graft for transplantation.
What's the situation in your country regarding hepatitis C?
C is a contraindication for transplantation in our country.
Yes, you cannot use this kind of organs, this kind of donors, or is a clinical recommendation?
It is not permitted here in India? It's not
We
allowed?
can offer
It's different that is a clinical situation or clinical agreement or recommendation or whatever, or is a legal or illegal.
It's not illegal. You can offer the thing, it is left, the onus is left up to the liver transplant technical committee also to decide in consensus with the region it is being offered to, whether to accept that liver and also put it to the family as to the risk of transmission is high, and they will require to take, they will have to do their own anti-HCV antibody titers and take the treatment for hepatitis C if it is transmitted. So there is an expanded criteria consent that you normally take for HCV and HBV.
Mm-hmm. Okay,
So it's
but
not illegal.
the recipient has to consent.
Yes, yes, very much.
Okay.
Okay, so that's the same situation.
Yeah.
So we can do it here in India. matlab,
Yeah, the call is taken by the liver surgeon
Okay,
and then if he is convinced and he puts it to the recipient.
okay.
And if it is a high risk recipient, like he may be in fulminant hepatic failure, and that is the liver that he's likely to get, otherwise he's going to die. He may accept it. That is his call. If he says no, then nobody is going to force it on him.
Okay.
So option number 4.
Okay, you can use this kind of grafts because you have treatment. It's the same situation as meningitis before. No? You have treated, you can continue the treatment in the recipient.
He has to continue the treatment.
Yeah. The difference is that the recipient has to know that the graft is from this type of donor, right? Okay, we have to change the discussion because it's quite old now. For the next time, I said.
A 1,000-bedded hospital, 40 beds are in ICU, with a neurosurgery department covers an area of around 10 lakh population, where 2,500 people die each year. This hospital performs 40 heart transplants, 100 kidney transplants, 80 liver transplants, 15 pancreas transplants, 12 lung transplants, and 100 tissue implants per year. Although the hospital does some recoveries, most of these organs are recovered in other hospitals. Last year they did 10 organ recoveries, 4 of them were multi-organ recoveries, producing a total of 20 kidneys, 4 livers, 2 hearts, 3 lungs, 2 pancreas and 7 tissue recoveries.
How do you think about this activity regarding organs procurement, not regarding transplant?
Last year they did only 10 organ recoveries. Though it is a center which performs so much of surgeries, but their own data of
converting brain deaths or something to organ retrieval is quite low.
Yeah, it is quite low. You have a way to have an idea, more or less, is to count a donor per ICU bed. This is an easy thing to almost have an idea that which has to be the activity, the supposed activity. Then if you are 10, it's quite low. You have to increase. So you have to start to see where you have the problems. Probably is detection the problem, so solve it, create strategies between professionals, search for some key person who understand the process and want to take care of the detection and so on, right? Your hospital, how is it? Is in that situation, or you have good numbers? Think in your hospital, your facilities, and more or less your donors. What do you think? It's the best you can do? Less? So you can increase, you know it. You want to add something?
No.
Okay. So the key is that they have to improve. So they have to analyze how is the situation, how is the detection inside the ICU, how is donor management, where are the tricky situations or the tricky situations where they have to know how is in the place, and then make some proposals to arrange the situation, right?
Is 3 or 4? Answer is 3 or 4.
Is 3?
In fact, I can add just an idea. This is quite real in some places. This is not theater. This is real. I know some hospitals, transplant hospitals, very high rate of transplant activity, but very poor donation activity. So it's your mission also to push these guys further and to improve their activity. I'll give you an example. My hospital is a transplant hospital also. We have currently, because we increased our bed capacity, currently we have 30 ICU beds. We have 51 donors per year. So you see the difference. 30 beds, 51 donors.
And you don't have DCD.
We have uncontrolled DCD, not
Yeah.
type 3.
But if you cannot,
If we could add
You will
the
double
type 3,
the numbers.
yes, of course. Yeah.
you will double the numbers. So the options are there. We have to catch it. Okay.
So how many ICU beds we have? So our target should be at least those for a year,
Yes.
per year.
It's
But-
a
Instead
broad
of-
number.
okay, okay.
We have other
Okay.
indicators, more soft, and you can analyze every part of the process. But to have a big picture, is 1-1.
Okay.
Okay.
Right.
You're smiling.
Yeah. So this is our topic. No?
Yeah, which of the following definition of brain death donor is wrong? So we are now in the definition premise.
Possible potential.
You can read. You can read.
I can read?
Yes.
Yeah. So possible deceased organ donor, a patient with a devastating brain injury or lesion and apparently medically suitable for organ donation. Potential donor, a person whose clinical condition is suspected to fulfill the brain death criteria. Eligible donor, a person who has been declared dead based on the neurologic criteria as stipulated by the law of the relevant jurisdiction. And actual donor, a consented eligible donor in whom an operative incision was made with the intent of organ recovery, or from whom at least one organ was recovered for the purpose of transplantation. is wrong.
The wrong one.
Wrong
We
one.
need.
Second one, yeah.
Hmm?
Eligible donor. Because the eligible donor definition has to also include that he is medically suitable.
Yeah. And the declaration is before you have a potential. No? Remember this morning when we talk about possible, is everyone who could evolve to brain dead. And we are thinking that maybe in the future could be a donor. Potential, we have the great suspicious of brain death, or we have determined brain death yet, right? It's just because we have to talk all in the same language, and if not, it's impossible to compare. We cannot bench between us if we are talking of different things. So we need to use the pathway, right?
Yeah.
Okay? Six.
A 50-year-old male patient suffered a motor vehicle accident with head trauma. The GCS at admission was 8. Brain CT shows multiple cerebral contusions. In neurocritical ICU, treatment of ICB was performed with mannitol, hypertonic saline, and neurodepressant drugs. 4 days later, neurological worsening was observed and intracranial hypertension was uncontrolled. 1 day later, the diagnosis of brain death criteria following whole brain death concept was established. Which of the following answer does not correspond to the diagnosis of brain death of this patient?
Instead of whole is my situation, think brainstem. Okay? Yours.
So we have to choose a false answer. First option, in this patient, diagnosis of brain death was made with a complete clinical examination plus 1 instrumental test. Prior to clinical examination in this patient, the potential interference of barbiturates on brain death diagnosis was reversed with flumazenil. 3. After painful stimulus, the patient did not show decerebrate posturing or decorticate movement. However, some spinal cord reflexes were present. In this patient, the apnea test showed the absence of spontaneous aspiration in the presence of CO2 blood level higher than 60 millimeter of mercury.
Is yours.
So which one is the wrong choice? Remember, we are talking about whole brain death concept, okay? So, comments on the first. Is everything okay?
Second,
So, clinical examination of brainstem plus
one is
instrumental test.
EEG can be the.
So, this is okay.
This is okay. Yeah.
Mhm.
Does anybody disagree? Do you disagree? No? What about this, the second option? I heard someone commenting on the second option.
So this is wrong. This is wrong.
Yes.
Not for each other. Flumazenil is not for barbiturates.
And even if it was, in fact,
It should not.
Short-acting drug.
Mhm.
Yes.
There's no sense doing that.
Yes.
So we do all agree on that, right?
Second. Third. Yeah, third is correct.
Yesterday he talked about the reflexes, the core reflexes. You remember?
If you remember, our that guy lifted the leg.
Lazarev.
That didn't mean anything.
Yes.
And you proved that with your clinical evaluation, right?
Yes.
So this is possible.
This is possible.
What about the last one, the fourth?
Fourth is correct.
So we achieved our goal, right? More than 60 millimeters of PCO2.
Yeah.
Okay? So it seems obvious.
Second.
I think he is not convinced. The fourth?
No,
Yes?
yes,
Do
there is.
you agree with that?
No. I'm just still reading that. In this patient, the apnea test showed the absence of spontaneous respiration. In the presence of CO2 blood level higher than that means
Yeah.
he is brain dead.
Yeah, it-
this is
it-
correct.
Yes.
So
The,
this is not wrong, right?
no, the fact is he is in hypercapnia and he doesn't breathe. So the center is destroyed. That's the point. That's it. Yes.
Exactly.
The apnea test is well done and the result confirm that, no. Right?
So we are all
For 2.
agreed
2. Option 2.
right?
Do you use barbiturates for hypertension or not? In pediatrics, neither? We still use in pediatrics sometimes, and it's a huge problem.
Well, we also use it in adults. And sometimes it's a problem because we have to look for the ancillary tests
Yeah.
to demonstrate the lack of perfusion.
Okay. Okay, next. Is your time.
Yeah, sure. It's okay. A 62 years old female patient who is under anticoagulation because of chronic atrial fibrillation suffers a sudden decrease in conscious level. The admission in hospital GCS was 6 points. HCT scan showed a massive spontaneous intracerebral hemorrhage. She was intubated and transferred to the ICU. 3 days after admission, the clinical examination, no under effect of sedation, showed pupils non-reactive to light, corneal reflex absent, absence of oculocephalic reflex and oculovestibular reflex, absence of motor responses, absence of oculocardiac reflex of and of gag reflex and cough reflex, no respiratory movements after CO2 level in the blood of 65 mmHg, and no increase in heart frequency after injection of 3 milligram of atropine. CT angiogram showed the lack of intracerebral flow. In discussion about the diagnosis of brain death of this patient, there were several assessments, but only one is right.
Okay, let's see.
So the option 1, the bilateral absence of corneal reflex is enough for establishing the brain death diagnosis. Oculovestibular reflex is not needed to diagnose brain death. Gag and cough reflex are always part of the brain death diagnosis. Lack of flow in cerebral angiogram is enough for brain death diagnosis, and clinical examination is not needed.
Okay, do you remember the question? There's only one is right.
Just
I will forgive you if you fail this.
I want a question. Gag and cough reflex.
Okay.
Okay, so let's go one by one. I think this is ridiculous, right? You all agree on this. What about the second? You've been through this the whole morning, right?
Mm-hmm.
Those we discussed are always part of the evaluation. And we also discussed this. The ancillary test is not a structural diagnosis. This is a clinical diagnosis, not an exam diagnosis. So the exam is to help us when we have some doubts, not enough to establish diagnosis. Okay? Exactly.
What he said?
Support.
Yes. Yes, but you have to be convinced that it's brain dead. You cannot do that to solve your doubts. No. First, you have to be convinced someone is brain dead, and then, in my case, to shorten the time, the waiting time, I do ancillary test. But the exploration is done first. It's just to confirm that and not have to wait 6 hours or 24 in my country.
That case of the phenobarbital or the pentobarbital, whatever. If I was going to wait the 3 or 5 half-lives, it would take me 5 days.
Yeah.
I won't wait 5 days to clear with the situation, so I will for the ancillary. Even though I know we still have some barbiturate on circulation, but I'm quite convinced that individual is dead. So I will prove that will be ancillary and shorten the time of diagnosis.
Mm-hmm. Right? Do you agree? Okay, number 8.
Yeah. So a 55-year-old male obese patient was admitted to the hospital after a cardiocirculatory arrest. CPR was performed for 50 minutes and he was transferred to the ICU 36 hours after he developed signs of brain death. Reviewing the medical history, the patient was found to drink alcohol, 1 bottle of whiskey per day, smoking 2 packs per day. His blood tests were as follows: follow creatinine 0.62, SGOT 781, SGPT basically elevated, and bilirubin of 1.05 and INR of 2.1, which are all I mean LFTs, and they are not normal. Creatinine is only 0.62.
Okay.
Maybe.
Okay, that means it's a donor. No? You are thinking in what to retrieve. But the surgeon will say, it's too fat, maybe the liver is not going on. Look at the figures, 700, 900. So, well.
So option 1.
Yes.
Prolonged CPR, obesity, severe alcohol consumption, and highly elevated LFTs show this is a very extended criteria donor. Option 2, heart, liver, and kidneys should be considered for transplant, pancreas only for islets. Third option, this is not a donor due to too long CPR with clear impact on the organ function. And fourth, this is only a kidney donor because the impact on the liver function is significant and this is not a suitable liver for transplant.
Sure. Yeah. 4.
We'll vote for 4.
Okay.
Yeah.
But we will try to get this donor. It's not an excellent donor, we know, but it's 56. It's a young donor, but a lot of comorbidities. So kidneys probably will function in the recipient, so we have to try. Right? Any other thing? And what about tissues? Do you want tissues of this patient? Cornea? Yes. And skin? Someone tell me that you do perform skin? Bones? Why not? Heart? Probably as a graft node, but maybe as cardiovascular tissue.
Tissue bank.
Yeah, it's a smoker, but yes. Okay, right. Nine, please.
Case 9, a 55-year-old woman admitted to ICU due to the acute severe hemorrhage secondary to the bleeding of brain tumor. She was diagnosed 6 months ago by biopsy of astrocytoma grade 2 tumor. She rapidly progressed to brain death diagnosis.
We need a neurosurgeon. Grade 2. 55.
लो ग्रेड होता है.
Well, 4, maybe or maybe not.
Yeah.
So the sentence is very affirmatory. So I wouldn't agree with you. Second.
And the third? Why not? So you have the classification. You have to go to the classification. No? The problem is when you have this kind of donor, the real issue is who will accept the organs. It makes sense if someone will use these organs for transplant. If not, doesn't make sense because when you have the grafts, you have nothing to do. They go to the trash. So if you have this kind of patient and it's a new one without ventriculostomy and so on, you can balance that, but you have to offer and see what they say about the donor. If they accept it, we proceed. If they don't accept it, we don't proceed. The major concerns were from the surgeons, the ones who has to accept the organ. I think it's more fair to inform him. The risk of metastasis is very, very low, you know that. But you have to inform that the patient who is the donor has that. I think, in fact, they don't explain this at the end.
Sir,
but you should.
actually this question is very valid, but problem is that the number of patients in waiting list are more and donors are very less, so you can't have the choice or liberty to choose the healthy donor from this type of cases.
We take informed consent in such cases. When we offer such organ,
Mhm.
we ask the recipient hospital to take informed consent. Informed consent means well explained to the recipient that this is what the donor is.
That's good.
Everything is explained.
These cases will always implicate discussion,
Yeah.
a broad discussion among all parties involved.
Mhm.
The last sentence in this discussion says that it is essential to perform an autopsy after organ recovery to identify the type of tumor, especially when the cause of death was intracerebral bleeding or uncertain etiology.
But not in the case of astrocytoma. You have here the biopsy. When you don't have the biopsy and you want to proceed, then you need to know more or less, but it's to risk very much.
In this case, the diagnosis is established based on the biopsy. It's astrocytoma grade 2.
Yes.
Otherwise, there are several tumors who can present with the bleeding. It can be metastasis involving the renal cell carcinoma. In that case, that is a metastatic disease.
Mhm. It could
There
be,
is a limitation, yeah.
but in that case, we believe that is astrocytoma. Okay. Probably we will ask the family to have the histology of the brain, the complete brain, and to see that we are not wrong. But the problem is, if someone accepts this organ, they are on the recipient yet.
And you have to balance between the need of the organ, if it's too urgent or not, and if you are willing to take it.
Yeah. If someone will die because he is in emergency, fulminant hepatitis or so, whatever, they maybe use that as a bridge to a new transplant. But that's the option of the patient. No, you accept that risk, and in the future we will search for another liver, and you will change it. It could be an option. For the recipient, is the option. There is no another one, because if they don't get the organ so soon, he will die.
So there is a concept of bridge transplant. Now this is a new concept for me, but one transplant
Yeah.
is done as a bridge.
Yeah, we do that. We can use mechanical devices as a bridge to transplant in heart or in lung, but sometimes we use an organ as a bridge too, because the patient will die, then the first that we have is more or less acceptable, then we perform the transplant, and then, yes.
Because very severe people suffering from liver disease, they don't have any support.
No.
Whether an organ or that.
Sir, we have one question. We have long waiting list for this end organ damage. If once they have operated, they have received the transplant, now they are requiring again surgery, who will be given preference? First time waiting, or those who have
I cannot quite give you a straight answer to that. That will depend a lot on the waiting list and on the choice of the people in charge of the following of those patients. They will decide according to the priority they establish for the patient. But of course, if you establish the transplant as a bridge with an organ that is not so good, perhaps you will wait for the next chance to substitute that organ.
No.
And it's used only as a bridge.
You will do that in a certain organs. That means heart, that means liver, not for kidney. It's not a bridge for transplant. He can wait in dialysis and then you have another organ. But if he will die, you have that option. Yeah.
The no to allocation criteria for kidney, not as a bridge, but if there is a primary graft failure, allograft failure, then there is an additional point given to the patient.
Ah, yes.
If the
Okay.
failure has occurred less than 1 year, it is 2 points, and if it is more than 1 year, then it is 1 point.
Okay.
It is added to their scores.
Mm-hmm.
I recently had a conversation with the cardiac surgeon of my hospital, and currently he has a few patients supported by a left ventricular assist devices, and they are doing perfectly well. And he told me, I'm not going to transplant this guy with some organ that I'm
No,
not
vendrá.
trusting 100%. He's doing his life perfectly good with a little with the device.
And where can the destination?
What?
Left ventricular assist device
Yes.
nowadays is also a destination.
Yes.
Yes.
It could be.
Case 10. A 23-year-old man is admitted to the hospital after being involved in a fight. He was hit by a hard metal on his head. Upon admission, he was awake. Few minutes later, he started to become confused. He was intubated and the CT scan of the brain revealed a massive subdural hematoma, for which he was operated and transferred to the ICU. On day 3 post-surgery, his condition deteriorated and a repeat CT scan revealed a massive intracerebral hemorrhage. On day 5, he was declared brain dead. The nurse in charge approached the family alone for organ donation just 1 hour after he was declared brain dead. The family became enraged and refused the idea and wanted to sue the hospital for mismanagement.
What shall we do now? The police. To escape.
Move to another city.
Yes. So, you have to start a conversation with this family, no? And you need your soft skills to manage this. But you have to have into account that sometimes, yeah. Well, enthusiastic, I don't know if it's the word, but but someone professionalized has to do that, right? But the problem is sometimes you have to reorganize or restart the conversation because you are in that situation. So how you approach this family? Because they want to sue, and well, they can do that. No? When we talk with them, and sometimes we have this situation, they explain that they can sue the hospital, but they can be organ donors too. So it's the way to have an agreement between us. No? One thing is not. Tell me. Yes.
There is no question. This is the situation.
Yes.
The nurse has informed, and family became enraged and refused the idea and wanted to sue the family, sue the hospital for mismanagement. That is a very usual thing in India.
That is
Nothing
a
new,
usual
nothing new.
situation.
Yeah.
So you need to know how to deal with that.
Perhaps this was not the best approach.
No.
Right? We all agree on that.
Yes.
Instead of the nurse, the in charge should talk to the family.
Could be the doctor, yes.
Yeah.
You can change the nurse for a doctor. For someone who is not familiar with how to approach regarding the organ field donation, and they make some, let's say, non-polite approach to this situation, right? But doesn't mind. If someone do, you have to do extra job, but you have to make a family approach to explain the situation, and they maybe decide not to be a donor, but they almost understand which is the situation, and the loved one is dying, right?
Near and dear one has become very angry.
Yeah.
So, what is the solution? So, it is a family.
Conversation, conversation, conversation. And when you have finished, restart again. That's the solution. Yeah.
And there's another very important approach here. This guy was admitted after a fight with a severe head injury. The first talk I always have with the families of my patients, and now I'm talking as attending doctor, attending intensivist of a patient, not organ coordinator. I invite them in, they sit down in front of me at my desk, and I explain everything to them. What happened, what's going on now, and what do we expect from that situation. And if we don't expect anything good, I tell them, I don't expect anything. So let's see what comes up. But you can expect the worst from this moment on, because this is not good at all. And most likely, he will die. So we must be very clear with them from day one, from moment one. Because when you inform them of this outcome, that will, of course, they won't be very happy about it, but it won't be such a surprise.
So yesterday we talked about the continuity of the information. No? That has to be coherent. What they explain in emergency, what the doctor in duty in the ICU explained to the family, and the final situation. So if they have been alerted that the situation is very poor, well, they can be angry with us, but it's comprehensible.
Here cause of injury is fight. So that in itself indicate that you have to handle the situation according to that only. Because they know a lot of litigations. Fight. Whole family is on the same line, fighting. They are angry.
But if you lose a daughter of 23, I will be angry too. No? I will be sad, I will be angry, maybe I scare, I shame you. I don't know, because I never know how I will react if I have this situation in my life. Now I'm rational, but maybe I'm not rational this day. Yesterday we talked about that. We have to accept how they react. Okay? And not punishing them because they react in the way that we don't like. Right?
We have to understand what they are feeling. Understand, but not lie with them. You have to understand.
Sir, here we understand everything, but their family don't want to understand. This is the issue.
That's not
Yeah.
No.
No, I disagree with you. And I've been, all over these years, I've been facing situations like this, very serious situations, complicated situations, even in a foreign country where I work, in an Arabic country. And I will tell you the situation. I was in a hospital in Dubai. A young man
Take
went
the mic.
for a New Year's Eve.
Yeah. Take the mic because sometimes.
A young boy went to spend New Year's Eve in Dubai, and he was hit by a bottle thrown from a building and brain dead. Family was enraged also. They did not accept the brain dead diagnosis. They wanted another opinion. They wanted the opinion from a guy from Germany. They didn't know the doctor, but they've seen him on internet, and they wanted his opinion. I was there with a Brazilian colleague working with the local authorities, and we went to the hospital to talk to that family. They didn't speak English, so there was the head of the department speaking Arabic to them, and we were there. He was translating. Then they looked at the big boss, and they asked who we were. He told, this is a Portuguese doctor, that one is a Brazilian doctor. And they asked, can they give their opinion? Yes, sure. We went next to the bedside of the patient with one. We had 10 men in that room, rage men. The father, the brothers, and the cousin. The calmest one was the cousin, and he came with us. We performed all the examination that we did this morning to demonstrate the brain death. Explained everything to him with gestures. He was understanding. At the end, they accepted the brain death diagnosis. They didn't accept donation, but they accepted the brain death diagnosis, and everybody was calm at the end. So we have to know how to talk to these people. They didn't know me. I didn't know them. I didn't speak their language, but I was able to demonstrate to them that their relative was dead. So this is all about communication and skills of communication. No, only once. They already have done everything. The death certificate was already issued, but the family was not agreeing with that. So I only performed one set of clinical tests, of clinical examination, just for demonstration purposes. And they believed my demonstration. Okay, that's one option. We discussed that in the morning. In this case, I don't think the recording are the best solution for this. You have to face people and look in their eyes and speak to them in a manner that they understand you and believe you.
Time. You are in a hurry, for sure. We are all in a hurry. But if you don't spend enough time with communication, you will lose all. And the worst is they live angry and enraged with us. And that's the point. So you don't lose time communicating. You earn. Okay?
It's about trust also. In the way you communicate,
Yes.
you earn their trust.
They trust in him because he explained all the exploration and they finally understand what they are trying to say. Probably the doctors in charge try to do that, but they don't get the connection.
There is another case, also in Dubai. 17-year-old boy. Died also. French mother and Danish father. The Arabic chief was explaining everything and trying to obtain their consent for organ donation. Was not being very successful. Then, once again, myself and the Brazilian colleague, we stood up and we spoke to them. Recently, they had a ceremony 1 year after the death of the boy. They had some events and they invited the mother. And she told that Brazilian colleague that is still working there, she told, okay, you are one of the doctors that talked to me. I remember the other one, the Portuguese one. I don't remember what you told me. I don't remember your faces. But I remember your looks, the way you looked at me. So this means something.
It's not what you say, but how you say that.
Exactly.
Yeah. They don't remember what you say. Never. They don't remember what you say. They remember the way you say that, yes. And that's important too. For that you have the skills. You have to use it. Well, maybe it's the last one.
Thank you. You are the transplant surgeon in a community hospital. The transplant coordinator informs you that there is a 37-year-old male donor with blood group AB negative, and you have on your waiting list 2 patients who match. The first patient is a 55-year-old male patient who promised to donate $2 million to the hospital when he gets a liver transplant. The second patient is currently in the hospital under treatment and desperate for a liver transplant. Currently, the hospital is in need for money. The transplant coordinator is waiting for you to decide which patient will receive the organ for transplantation.
Split the card.
Yeah, split.
It's Solomonic decision.
So anyway, it's a situation that has been.
Have the micro, please, because we cannot hear.
Take it.
So what shall you do?
No, the thing that is mentioned about the other patient is looks like the one who is offering money
It's better?
doesn't look to be sick. No, can we go back to the previous slide? Ma'am, can we go back to the previous slide?
Yes.
For a moment. So, who promised to donate 2 millions when he gets a liver transplant, but nothing about his seriousness or grade or anything, score.
Okay, so you have one guy willing to offer money and another guy severely ill.
So priority for the second guy.
But sir, that the guy who is having money will give money to the hospital. The hospital will be treating so many patients. So it will be a lot of patients will be.
Yeah, and the second will die.
Poor guy's family.
Yeah.
Who is on the higher priority list? I think the split liver is the better option.
Yeah.
Act.
The transplant surgeon decides who receives or not.
Who receives the organ is outside the scope of the organ
No.
donation.
No. You have your rules in your country. The allocation of the organs is done by rule, and there is a consensus and so on. But when I don't know how it works here, but in our country, when the organization offers the organ to the hospital, the final word is from the surgeon. But the allocation system is common. So we have this, and you said, okay, that match to this person, so it's that hospital, and they call the hospital and said, hey, we have an organ for that person. How is he? Because maybe it's worse, or he died, or whatever. But the last word is the surgeon.
In auto, the waiting list is frozen the moment the alert is there. So whatever is your ranking on the waiting list, whatever had to be done, whether you wanted to list a person as super urgent criteria, had to be done before the offer for the organ came. So you're doing it on a daily basis. It's not when the liver is offered, you suddenly decide to make your patient super urgent. You cannot do that. Once the alert comes, the waiting list is frozen. So whoever is first will get that liver.
Yeah.
Unless he has been updated the same day before the alert came.
But
Not to ask how many. We get back to back sometimes we don't get the alerts. One day we get 3, 4, 3, and then there's a lull for some days.
Excuse me, madam, my question is that if 4 patients are waiting, do they know each other?
No. What
They don't.
happens, presently I would say that if there is a
if we have 4 patients in AIMS waiting for the kidney, so do they know their order of preference? Madam, how they are displayed in list, whether there is a unique number or name is there? Madam, if during the process of waiting somebody dies, how they improve the list or modification is done? Madam, if any waiting person want to go to abroad for the transplant, do they inform you?
Improve our existing system, you know, at par with what you are having. I mean, did you guys get time to interact with each other? Because, you know, we have discussed a lot about the patient management, and I'm sure all the delegates who have attended this meeting, they are going to get immense benefit out of it. I myself got benefit out of it. I am physically missing from this meeting today, but I'll see all the lectures. I have attended the course before also. So, I mean, I'm sure you must have interacted with each other. I will be very happy if you have a central registry for the NOTO, and, you know, everything is transparent. Whatever the questions are being asked by the, these are very genuine queries. I also had this query last year, but then gradually I got used to it. So,
Gradually you learn,
yeah.
there is a system, definitely. Every hospital have a username and password. You can start registering the patient that you read, and you can access that. It's a recipient list, follow-up list, everything is there, but it's just that you have to start.
Yeah, I think there was a group.
There are hospitals who are not doing transplant and retrieval, but if you want to create awareness as an activity, being doctor, you can do a pledge and you can register the pledge in that also. So every hospital have the access, but to hospital level, hospital have access, SOTO will have a state level access, region will have a regional. You cannot intervene in each other's.
Which are the hospitals? Can I have a raise of hands in this audience who do not have an existing disease donation program? All of you? 1, 2, 3, 4, 5. Live donor. So I think Dr. Archana, you need to, they need to get connected with you to solve, because this course is just the beginning. You know, you will continue to have doubts. This was my understanding when I started doing these courses, and even ATLS or BLS, whatever courses you do, when you do the course for the first time, it's just a teaser, you know, you get the hang of it, hang of the subject, what is brain death, organ donation. Now when you will go back, you will have some, you will be a wiser person. I mean, in front of 10 people sitting in front of you, you will be a wiser person for sure when you go back. Now what we want from you is, we want you to do such activities, you know, small symposia, a half-a-day course. Call any of us, me, Dr. Shroff is there, and anybody from Noto will be very happy to help you out. And we should do this activity on a very, very regular basis. That is the only way we can improve the system. I am persistently saying it to Dr. Archana also. You know, the media, we are blaming the public, you know, that people are not coming forward to donate. My personal belief is, the one single important factor which is responsible for poor donation is the knowledge gaps. I just talk about knowledge gaps, knowledge gaps, knowledge gaps, nothing else. This audience, 50 people or 40 or 30 who have left here, they need to be very convinced brain death is death and it is legal. How to do it? You should know it. In the morning there was a session going on in the morning at 9 o'clock, and I was not surprised, rather I would say that, when the discussion about the fear of the neurosurgeon about the brain death certification came. So somebody who is not into the subject, he could be an intensivist or a neurosurgeon or anesthetist, professor or senior resident, does not matter. Ignorance is ignorance. So you have to teach them, you have to train them, and before that you need to train yourself.
Well said. Okay.
Emergency requirements of the recipients or his emergent status. So, and also you also said that the final decision is taken by the Apex members. But my question is whether the Apex member also considered on a daily basis? They do sit or they do consider on a daily basis? No, not about responding. About updating that list. If suppose I send a... Okay, so it's an efficient and live system.
So one of the things that's effective is setting up a donor management council or a organ donor committee in your hospital. And that committee can consist of physicians. It should consist of physicians, nurses. It can be transplant surgeons. It could be neurosurgeons. It could be your cardiac transplant specialist. It might be a nephrologist. It could be a hepatologist. You should have administrators on there, and you should also have family members on there. Family members are crucial. The reason family members are crucial is because they keep you balanced. We listen to all these things that we talk about today. What's missing in this room? The family members. They have a completely different perspective. Well, you know, I don't think the family would go for that. If we sat down and talked, they wouldn't go for that. And I think what you'd find is the family would say, of course we would go for that. We want to know about that information. But that becomes really important. So you set up this committee, you meet on a monthly basis, you review charts. This becomes a quality improvement project. You begin to look at your charts and figure out, do we miss an opportunity for donation? If we missed an opportunity for donation, what do we need to work on? If we recovered organs from a donor, what did we do well? What are we going to do better next time? Those things become really important. The importance of you today is that each one of you now becomes a champion, hopefully, as you go back to your institutions, and you begin to recruit more people. But the way you do that is not just in your respective units, it's throughout the institution. It's changing the culture of the institution, okay? One person can't do that. One person can start it, okay, but it takes an army to win. It can be. Absolutely. Yeah, family.
What is their perception? What myths they have got? Lack of understanding, social beliefs, taboos. You know, people coming from the rural background and from the urban background, they are different. People living in the nuclear family, joint family, they are different. I mean, when you start talking to the family, you will get so many surprises. You can't even imagine. You have to be with the family to see. You know, we as clinicians are just concerned about certification, apnea test, but at the end of the day, this is something extremely, extremely important. Very well. No, anybody you pick up, suppose any friend of yours who is not a doctor, you could get them and ask them, what will you do if something happens to your near or dear one's XYZ person? What is your perception? Do you know about brain death? Train them, and then you again ask them after a month, let them see the media and other things, and then see. So by family member we mean somebody, or maybe you could take the family of somebody who has died before.
Yes.
Okay, somebody you could take up, or maybe somebody who has actually donated also. Those people also you can keep them on board.
So a donor family is ideal.
Yes.
And the reason that they're ideal is because they've gone through this process. Here's the thing that we hear all the time. I don't think the family would go, they don't want to be asked about donation. It's too much for them. They've already been through so much, but we don't know that. We think we know that, okay? If you ask those families, how do you know that they've been through so much? If you ask families, organ donation was the easiest decision for them to make. Why? No, it's true. The reason it's true is because all the other hard decisions have already been made. Parents are altruistic about kids. Now, spouses are different, but, you know, again, we have specific laws. We have, you know, advocacy for donation. You can make a determination if you want to be a donor or not. That's legally binding in the United States. But you should have or set up a donor council in your hospital. That becomes really, really important because that helps drive the process. And it also shows that the hospital is committed to having or working with end-of-life care.
And I think the NOTO should also, it's high time that you take the initiative to have some certification courses. To the best of my knowledge, we don't have any certification courses. How many transplant coordinators we have in our country? And what training they go through? I mean, I'm just, pardon me for my ignorance, but I just want to understand.
We do a 5-day training program, but now we are planning to have a 6 months training program that we discussed with Clovia also, and very soon we will be starting that. We have aimed to start in this July itself, where we are targeting the MBBS, BDS, Ayush, and then nursing, and then we are going to train them in high volume centers like IKDRC, PGI Chandigarh, and AIMS New Delhi for sure, where they will have at least exposure of kidney, liver, and heart and lung, so that they will be well versed with all the organ procurement management technique from the start till the end.
So this is what I was asking, not just 5-day course. I just wanted to
even I was not satisfied,
somebody should clear the exam.
Yeah.
Somebody with a basic you should have something like a basic qualification, You clear the exam, and then you work in the center for few, maybe 6 months or a year as per the existing model in other part of the world, and let them pass the exam.
That
Then
is-
you give them the certificate.
That is the reason I was telling everyone out
Dr.
here.
Shah, please come forward.
Yeah.
I know Arshita has been taking a lot of
No, no, no,
No,
please.
no,
Sir.
but she is
I was
doing
just
very well.
telling these people only that
please
you
come.
are the one who
Sunil,
can
because
lead
only these one and these one. is
lead the things, because when you go to your medical superintendent or director and say we want to start the transplant program, make sure you start the disease donation program first, because I get a call from lot of transplant surgeons across the country. We are starting this,
So-
madam, transplant coordinator. See, NOTO will only help you for how many months? 1 year, 2 year, down the line it is the hospital who have to own it, and until and unless you don't own it, it's not yours. If we provide you transplant coordinator, the salary which is given, that is 35,000. 35,000 में क्या मिलेगा? क्या करेंगे वो? They will not lead the program. They will follow. आप जो instructions दोगे वो करेंगे. इसका test करा दो, ये करा दो, वो करा दो. But you want a person who will go to the ICU, get you that किसका GCS लेसेस का क्या कराना है, उसके motivated persons होने चाहिए. वो जाके वो क्यों लेगा अपने ऊपर ये रिस्क कि वो जाके फैमिली से खुद ही बात करना शुरू करे? नहीं लेगा ना, या वो आपको बाकी चीज़. तो यू नीड अ पर्सन हु हैव अ अथॉरिटी, knowledge and lead. So there is a permanent cadre in this, even AIMS, the transplant coordinator. Even in PGI they have a transplant coordinator cadre. So when you are creating a transplant center in your hospital, make sure you you push for the transplant coordinator cadre as well. ऐसा नहीं कोई deputation पे डाल दिया तो वो 2-4 महीने बाद change हो जाएंगे. Then you will be again in that same problem. So it is very important. So when you are pushing for one system, push for all these things. This is as important as you are important in that.
I just want to say, I want to give a very honest perspective, because I have been in this program now for 27 years. The problem is why you need a transplant coordinator. One, you need a transplant coordinator to help the family in their moment of grief, brain death, to coordinate some activities on the floor, coordinating with the family, coordinating with retrieval team, with NOTO, ROTO, SOTO, with police. But what happens in our hospitals is that there is no identification of brain death. How many hospitals have death audits, tell me? Do we have any data? We only have a data of potential possible brain deaths. We have a data of 1 to 4% patients of deaths which we have in this country, who have brain death. So if you don't have identification, if you don't have certification, what is the transplant coordinator going to do? You ask how many coordinators we have trained. We have trained more than 3,000 coordinators as foundation. From 2009 we are training coordinators. We have done 16 training programs in NOTO as well. That 1 week, 1 month, whatever training program. Many of the coordinators are extremely good. The family conversation is the most important part the coordinator needs to learn. How to support the family. When to kind of be quiet, when to slightly gently push. That is very important to support the family. And in the whole training, they don't need to know the intricacies of kidneys and liver and heart and all that. But what they need to know is how to support the family. Many of these coordinators, if you listen to their stories, is amazing. They would be supporting the family for days. And many families would say no to donation, would themselves come forward and say yes to donation. And today, the 900 or 1,000 donations which you are having in this country are thanks to some of these trained coordinators who are very passionate about the program. Doctors are good, but doctors don't have time. They're very busy. After they're declared, the doctor and the coordinator together they go and speak to the relatives. Doctor tells them about death, and then the doctor disappears from the scene more or less. So the first reaction of the family is no. And it's a natural reaction. Most of these patients are so young, and a great tragedy happens, there is a death. So obviously the response is no. But you just need to support the family. Just take care of their small needs. Usko pani chahiye? Has he eaten anything or not? Has he got somewhere to rest? Those small needs, because all the formalities take so long. So, Dr. Gupta, your question is very right. And NOTO comes in, NOTO is an apex body. And Noto comes in where the allocation happens. Noto is looking after the whole program. Noto is looking after the education of the program also to make policies as well. But their hands are full at the moment. I can tell you that. Even the SOTO's hands are full. They don't have staff. They're not functional.
It is where the government has to come into the
So-
picture, and you need to approach the government. See, we send our...
Sometimes, Dr. Gupta, too much of government in a system is not good.
No, otherwise how will you change the system?
No, I'm just saying system should change.
How?
But I'm saying we need to work together. You can't just have one stakeholder leading the whole show. It is not going to be easy. It's a big country, and every state has a different requirement. What you have requirement in Delhi today is not a requirement in Tamil Nadu. Believe me.
I know that.
What you have requirement in, Rajasthan is not the same in Imphal. So it is all different. Our country is very diverse. There are 37 countries within this big country, and each state has a different requirement. So, and we are all kind of gradually going up the ladder, which is good. And last year was one of the best year in fact in the busy donation program. We did 900 donations, and we do many living transplants. So many hospitals demand for a coordinator for doing the living transplant training, not so much for disease donation today. But you all are intensivists and you are all neuro people. For you to, but if you can declare brain death, if you can identify brain death, I was speaking to Dr. Chandrasekhar from MAMSI here, and he said that every time they declare brain death, but they don't have a system in place of counseling the family. They don't even have license for retrieval. So what we need to do is we need to create the systems in the hospital more than anything else, so that there is an opportunity for the coordinator to speak to the family and support the family. You speak to the coordinator, Dr. Deepak Gupta, go back to the ground and speak to the coordinator, you'll know the real problems on the ground. What we hear is, our perceptions.
No, I have some idea. It's not the right forum to talk about it. Yeah. I have some idea about the
Since you
problems.
brought it up, I'm telling you. Otherwise, I would have told you.
My only humble, folded hand request to the Noto is, have some system for the training of the transplant coordinators. 5 days, 7 days course is good for nothing. Rotate them to few centers, send them across out of India. I send my residents, fellows across India to other centers. Why not send them to Spain? I'm sure there are ways out. One person, right now I'm so happy that at least 50 people are learning something. And by the end of this year, if each of them does just 2 donations in next 12 months, and next year when we meet together, all I am aiming right now is to cross a magical figure of 1,000 for India.
That will happen.
That's it. And I want each and every one of you to please stay in this field, help each other.
This training which you've done will help. Many of them will go back and do donations.
Yes.
Believe me. And those 1,000 figure will happen very soon. Believe me, Dr. Gupta. But again, I'll tell you, we have some excellent coordinators.
I know.
That's why don't send them to Spain.
You don't need to Spain.
Send them to Chennai.
No need.
No, it's true. The transplant coordinators, as Sunil was explaining, they are helpers. They have to be your right hand.
Yes, you have to support them.
But the ones that should go out and see how it's working, it's your people.
The managers, when we come to procurement managers, they should go to Spain.
Exactly.
They are very good with the whole management.
But in Spain, we are relaxed people.
Yeah.
We love party. We love being together. But really, I mean, I think what we were seeing.
Trained coordinators conversion rate, we have done this study everywhere, is 66% in this country. People like Pallavi, Lalita, their conversion rate is even higher. 80, 90%. So, the coordinators, and I'll tell you again, Indians are very giving. That's my personal belief. And I'm very sure about that. Wherever they are. Whether it's North India, South India, East, West, doesn't matter.
Can I give another perspective?
Yeah.
Yes, please.
See, there is no doubt about it that the system needs to be in place. And the most important step to that would be to have a very, very qualified coordinator in each hospital. You agree with that?
And qualified doctors.
Doctors also.
But I am telling you, this is only 30% of the efforts.
But it doesn't
Ask me
matter.
why. Ask me why.
Why?
Why we are not, what we are missing. See, what has happened, I have talked to a very, very qualified anesthetist from my hospital. And I gave him this proposition that why don't you start talking to the family who has just been brain dead. So he came out with his emotions. Why? Why would they give? Why would they give? So I try to analyze that why is it that we are not able to get it. See, you may have very qualified people. You may have a qualified neurosurgeon. You may have a qualified modulator. But Dr. Sukriti, she's not here, no? She hit the point, and I agree with her. She says, just like prevention of head injury, we need to start from the school. Don't you feel? There was a study, Dr. Gupta, you did it? At the gate of the school, there was a recording, and then after 1 week.
On Monday also.
Yeah, so the same approach has to be taken for organ donation as well. You know what happens? There's a big wall, and you yourself and your qualified coordinator is trying to break it with a small hammer.
Exactly, very small.
Tick, tick. That ball is 6 feet thick. And why is it so thick? Because nobody has cracked it from the other side. Nobody has tried to crack it from the school side, from the college side,
Yes, but this is a
from
very...
the awareness side, social awareness
No,
side.
but here
So we are
you're
all
going-
alone there. We are trying to hit something that nobody else, does it.
I think that one of the point, but maybe the problem here is what you are offering to your doctors. If you offer your doctors to talk to the family, they will say, no, it's not my job. What you have to offer them is a new professional pathway. Is the fact that they can open a new unit in their hospital.
I'm
That
a neurosurgeon myself.
no, I'm not talking about that.
Motivation at all. I am ready to motivate any.
No, but I don't know if you get
Very
my
good
point.
start.
What I think.
But the problem is that I'm all alone. Achha, why am I all alone, Dr. Deepak? Because 80% of my neurosurgery colleagues, they are so busy with their own work. Absolutely. And Dr. Mohan, Dr. Shroff will agree. They don't want to put their foot into this.
Yesterday did you hear Marty talking about it? Marty gave a talk.
Marty was sitting in Spain.
No. He said one important thing. You have got 6 people, 8 people who are probably not in support of the program. Just don't retaliate. Stay quiet, stay calm, keep working. Some nice people will join you in time to come.
So, again, this is where if you have a donation council, you find your champions, you bring them together. How do you recruit your colleagues? You don't talk to them. You have a family member talk to them. Because when a family member talks to a physician, the physician typically listens. May not listen to a colleague, but they have their own preconceived notions. Now, when they begin to hear what families actually have to say, that's where you turn the page. So this can't be done alone. The whole purpose of this is India is just like the United States. You have different regions, you have different policies, each state varies, but we have laws, we have guidelines to determine brain death. Those guidelines are the minimum criteria. In your hospital, you may exceed the minimum criteria. You may have to do more, but you still have to do the minimum. That's a clinical diagnosis. So as you begin to build your programs, certain things will fit into your program, certain things won't. You take the best parts of what you heard today and begin to build on those and see what works for your program. Because what works for one program doesn't necessarily work for the other program. And then you begin to share ideas across boundaries. And now you begin to collaborate. And that's what we did in early 2000 in the United States with the Organ Donation Breakthrough Collaboratives. We were flat at 30,000 transplants a year. We exceeded 44,000 transplants last year. We're hoping to do more than 50,000 transplants in the next 2 to 3 years. That's our goal. And each year it keeps going up. The number of donors continues to go up slowly, but we're doing more transplants. How did that happen? People got together and they started working together. You know, we have the best transplant program, we have the best donation program, but when you sit in a room and you hear, wow, they did 20 more donors than we did last year. We thought we were the best. If you don't compare notes, you never know. You can think you're the best until you get out there, and then all of a sudden you see this hospital doing this, and this hospital doing this, and all of a sudden you're not so great anymore. Friendly competition is not a bad thing. And then you go, what are you doing that we're not doing? That's how you make it work.
It's a teamwork.
So what I believe, it is a strong trust which matters. अगर treating physician and treating surgeon, they develop a trust with the family. And when defining or certifying death, after that it is the treating physician who has built up a strong trust. Trust is very important when communicating with that. Your communication skill will depend on the trust you are having with the patient's relatives.
Baby steps.
And
first step is increase the brain death certification rates.
It is the treating physician
Eduardo.
who will communicate first.
All right. 90% of
So-
donations happen in private sector in India, and only 10% at the moment are happening in public sector. And sometimes the trust deficit is more in the private sector. But disease donation is more about teamwork, and sometimes we don't have such a teamwork. In India, living donations are increasing in number. You know that. We do the highest number of living kidney transplants in the world, number one, not PMP-wise. We do the second highest liver transplant program, number one, not PMP, but not disease donation.
So, we are going to close, but before closing, we would like to share with you an event that can be very interesting for
Yes.
everybody.
So to each and every one of you, we have been planning this, actually I've been planning it for the last 10 years. It just had too many other things on my plate. 10 years ago and 12 years ago, we did 2 pediatric donor management summits. We are going to do another one this year in May. It is pediatric focused. Now you can say, well, I really don't care about pediatrics. I can tell you, you can learn a lot from kids. So I invite all of my international colleagues. It's a 2-day event. We're going to be talking about the whole process of donation, determination of brain death, DCD. We're going to talk about ex vivo, in situ perfusion, NRP, ethics, donor management. We're going to talk about collaboration. We're going to talk about how the donation coordinator works with the medical team, how we approach families about donation. So this is a big 2-day event. I would invite anybody who's interested, please take this back to your colleagues. And I do hope to have the opportunity to see some of you in the United States or perhaps again on some of my travels. Deepak, yes, and Chloe, thank you. For me, thank you for allowing me the privilege to come and chat with you and be a part of this 2-day course. This has been really, really fun. I always learn stuff. It's the cultural aspects that become so crucial. So I hope I've given you some good information that you can take back to your institutions.
Thank you so much, Tom. Thank you. So we came to an end finally. No, yesterday it was really like if the day had no end, but here we are. No, we are here. We feel much more closer than the first day. We have been living things together, and this is what we really wanted. You to feel that you are part of a new family, a new network of doctors that are working on that. And working on this field is really exciting because it's not only about talking about death, it's about doing research, about doing education, about, about opening a new professional or academic also. I agree, we have to be in the universities, okay? And this is gonna be done by you, not by a social worker. How to get into the university, how to do degree and post-degree things, how to do also how to train your colleagues. So this is your responsibility. You cannot take it out from you. You have to assume it, and you have to do it in the best way you can. So we really hope that a part of getting knowledge, you also get this kind of motivation that we all have. No, we always talk about the passion, and this is about passion. If you are not, when you are a surgeon, when you are an intensivist, you get passion about what you do. So if you become the responsible of donation, you have to do it with this passion. If not, it's not gonna work, okay? And we all, from the different levels, not only Noto, the hospitals, the professionals, we all have to work with the same idea and to help each other on that. So we really hope that you got that from all of us. Please, Tom, Takashi, you can come here with us. We are going to deliver you the certification of attendance of this course. And as you know, you will get, you will get, we're going, yeah. Coge a cada una, no, pero hazlo tú. Okay, share one, a little bit for each. So you know that the final certification, you will get it once you will finish the test on the platform, yes? But this is an attendance certification, and we are very proud and very happy to deliver it to you. So each of us, we are going to...
First name is
Exactly.
Himanshu Prabhakar.
Come
No
on.
better name could have come in my hands.
Okay. No, pero Joaquim, you too, come. A little pin. Welcome to the family.
Kokula Panit, who is arranging vehicles for you to go back. Okay. Dr. Vimi Tiwari.
Kukula, he is Kukula, please. Thank you so much. For that, you have what it's called organ sharing or exchange office, or and this exchange office can be linked to the national competent authority, the state national competent authority, or in the United States they have an independent organization called UNOS. It is really interesting to have this independent organization, independent or inside the Ministry of Health, because the things, I mean, coming back to the beginning, we know that donation and transplantation are based on the society. If you want to have the trust of the society, this has to be clear for everyone. If you are not able to explain how the organs are going to be allocated, and if you cannot explain that this is not your decision, it is the decision that it's shared by everybody, and that it's the Ministry of Health that takes care of that, then you are lost. Because what you're explaining is not fair, somehow. So these exchange office or sharing offices are in charge of sharing the organs, so that means all the logistics thing that it's important. Then the waiting list management should be done or should be organized by them. And then the transplant indications, that's really important. It is not possible that someone goes to your hospital and you tell them, no, we are sorry, but we cannot transplant you, we cannot transplant your liver because it's not an indication, and you go to another center and they say, yes, of course, we will transplant you. This also has to be a common rules of transplant indications. That's why this is an example of how it works in Spain. We've got from one side medical criteria, and then we have geographical criteria. How do we work on that? We have committees in where all the transplant centers are represented, and we meet once a year. We look the results, or we analyze the results from the year before, and depending on what has happened, then we will decide if we maintain the allocation rules or if we change anything, together with the national competent authority. So in Spain, we have we have allocation criteria that depends on medical criteria, like the national emergency, no? So in Spain, if someone's gonna die in the next 24 hours, this person is a priority for all the country, okay? And there is no discussion about that. Second priority would be children, and that's why in this moment in Spain we almost don't have any children in the waiting list. Then in Catalonia, in my region, we put the liver in this medical criteria because we are doing the liver allocation based on the MELD. You know MELD, well, it's a special score for the severity of the liver diseases. But then if none of these situations occur, then what we use is geographical criteria. So if I have a donor in my center, if there's no children in the waiting list, if there is not a national the kidney stays in my center. Okay? It's not the case in many other countries in Europe. Okay? We have a transnational system in the center of Europe, in where you have Germany, Netherlands, Belgium, blah, many countries that are working as a transnational system. If you have a donor in Germany, which is not really the case many times, if you have a donor in Belgium, the organ can go to Germany. So imagine the cold ischemia. But the matching is good. It's very good because you have a big pool, no? It's what I was explaining you before. What are these national urgencies? Those are also consensuated among all the teams, and here you have what for us is a national urgency: acute liver failure or retransplantation in case of liver, in heart shock, and we have different grades, and then the lungs. In lungs, it's not really a national urgency, but the teams accept that if one team says, I really need to transplant that person, we send all the information about the patient, the national competent authority accepts, and then we go on. And what is the geographical criteria? Geographical criteria means that it goes first to my hospital, if not to my city, if not to my state, then if not, it goes to national, and if not, it goes to international. The idea is not to lose any organ. And when we talk about waiting list also is so important. You need to have waiting list to make sure that the system is clear for everyone, it's fair. So, usually what happens is that every center will do, and if they do any change of inclusion or exclusion, they will transmit it to the organ sharing office, and there they are going to allocate the organ. So those are basically, when you include a recipient, it can be elective or for the urgency criteria. If you exclude it, it can be because you have already transplanted, because he's dead, because there is a medical deterioration or a medical improvement. An important thing that yesterday we were talking about, in Spain and in all Europe, you can only be in one waiting list. You cannot be in different waiting lists. You can decide in what center you are transplanted, but you cannot be in more than one center. Okay? So if you change the center, also this has to be informed to the organ sharing office, and well, that's the thing. And from Europe, we just share the emergencies. So as conclusions, what is important is that the organ sharing has to be regulated, of course. Any of the professionals involved in the activity should know these allocation criteria, because this is how you are going to show to your population that what you are doing is transparent, is fair, etc. And finally, this is not a static thing. It needs evolution. It needs to be dynamic. You need to analyze what has happened, analyze if you have any group that is being excluded or somehow they are not benefiting of this allocation, and then you have to change your allocation criteria. And for that you need consensus. So the national competent authorities should be helpers, should be the ones making sure that all the transplant teams are on the same track, okay? So that's basically the idea that we wanted to share with you, okay? So it's not your responsibility, but you should know how does it work, and you should push to make it happen. Because without that, you will never get the trust of the population. And now that we are going to go to different workshops, and I will see you in the family approach one, you can be as good as you want in your family approach. But if the system is not clear for the people, how long you can explain anything to them? If they wouldn't be able to be transplanted because the allocation system are not fair, why are you asking them anything? Okay? So that's basically the message, okay? Okay, so I don't know if you have any question about that. Please. Yes, well, ABO incompatibility, I mean, now we do it. We do it in.
My question is, say you have a recipient who's ABO incompatible in your country, but you have a ABO compatible recipient outside the country, what would you do?
If it's outside the country, we don't take it in account, because outside the country for us, when I was talking about geographical criteria, it is very important. The organs are generated in your area, you should preserve it, because in Europe, for instance, the problem is that we have very high And if we would be connected with Germany, that have 10 donors per million population, we have 40 donors per million population, all the Germans would come to Spain. So you have to be careful with that, no? The organs are generated, so that's why we don't see. But if you have compatible and uncompatible, go to the compatible. Because it really, I mean, you are increasing the cost, you are making the things complicated. Make it simple, make it right.
Are you doing ABO income?
Yes. Yes, we do it. But it's not the ideal. Questions? No?
During family counseling, when somebody asks us, a pointed question comes that whom are you going to transplant these organs? Show us the person. We do not trust your word. So this is a very difficult question to answer.
Well, no, because you cannot tell them to whom this is gonna go, because, so the answer is, this is gonna go to the one that in the waiting list needs the organ and has the better compatibility. And this is something, and then it's when you explain the system, this is something that is under the responsibility of the Ministry of Health. We have waiting lists that are, and that gives, at the end, they don't want to know if this goes to Mr. John or to Mr. Peter, because they don't know them. The point is they want to know if this is going to be fair.
Yes, sometimes there is an apprehension that there is something unethical going on.
That's why you, since you are the ones talking to the family,
yes,
you should pressure, pull or push or whatever to the authorities to make sure that this is fair. Because if it's not fair, I'm sure you don't want to be part of this neither.
At the time of taking consent, it cannot be that prolonged that we ask the authorities to make them satisfied regarding these points. It's a situation which we are handling, and it's a problem we are facing in converting a potential donor into an actual donor.
Yes, well, in the conversion rate, you will have many things that will happen, no? Yes. It can be excluded because of poor management, it can be excluded because the family approach, etc. Yes. This allocation thing, I think that where it has more impact is in the family approach.
Yes. Is it possible to show them the waiting list for our country? I mean, is there a site?
From our perspective, yes, it is not feasible because it's anonymous. So we don't want the donor to know the recipient because
no, not exactly, but at least the list of donors.
Of course. The same that you can show them. Exactly. I mean, you have to do everything that is possible to make them understand the process.
Make them understand.
So if you can explain them and you say, look, the waiting list is working like this. We are going to get inside the website, blah, blah, blah. Of course.
Yes, maybe that has to be done.
Yes. I mean, it has to be done depending on the cases.
Yes.
So if you feel that these people need to know more, you can show them the laws, you can show them whatever you want. But people what want is to see in front of them someone that they trust and that knows about this. That's why when we discuss about who should do the family approach, it's important that the doctor that they trust is doing the family approach. Because if someone from outside comes, they don't know them, they don't know in what part of the system they are, maybe they lose this trust.
Yes.
But that's why you should be an expert on this.
Okay.
Please.
Ma'am, I haven't started as yet, but still I can expect a few questions from the family. The first thing which I feel, if I put them in their place, is that are you going to take all the organs from my son's body, or are you going to take some specific organs? So I personally feel that I would like to not shock them by saying, we are going to take out your liver, your pancreas, your intestines, your kidneys. The moment they listen to this, immediately, they will feel that my body son's
like
body is going to be mutilated.
Yeah, exactly. No, it's a bad idea to have the shopping list.
Yeah.
Okay, this is a very bad idea.
Yeah.
You have to talk about donation in general, but then of course, if they ask you,
Yeah.
you have to answer.
No,
but not as your message. The first would be, we will take 2 kidneys. No, this makes sense.
Actually, I talked to somebody from my country who is into the laws. Dr. Anil was here.
Yeah.
So it is, see, we can't tell them lies, because once if we commit to them that only kidneys are being taken, we can't change the statement after 10 minutes. No, it's not only the kidneys, the other organs also have to be taken out. So we have to be very sure about what we are saying right in the first place.
And what is in your law. Okay,
Yeah.
because as we said, it was not in the course. In tissues, we have to do that.
Yeah.
But it's at the end of the whole family
So,
approach.
ma'am, what I was planning was that I tell them, and yesterday I confirmed it. It's not that I'm saying like this only. We, any center, and Dr. From Jaipur, Dr. Purohit, is he here? So it's a law that if a center is providing a brain dead donor, then one of the kidneys is supposed to be utilized at that particular center. That is a law here.
Yes, that's
Okay,
right.
and that's a very good law for the family. I wanted to say that once the patient's family knows that one of the kidneys is going to be donated here itself in this particular center, and they'll be aware as to which particular person is having that child's kidney, so they would definitely be inspired.
Yes, but be careful not to make them easy to identify who's gonna be the one receiving, because it is, even if you see in the United States, you have you have this thing about no anonymity in between donors and
Yeah.
in Europe this is something that first the families don't want, and second, it is not in our culture, and we are very afraid to create a conflict. Because imagine knowing the family of the one who gave you your liver being there saying, you don't have to take alcohol, be careful with this, be careful with that, or asking you for something in return, hey, you're living because of us. It is a moral, I mean, it's quite hard. It is very well done in the United States, but for us, this is something that we don't want to get in.
Yeah.
I don't think in India it would be a good idea to do that.
I differ from you, because I feel that once you assure them that the kidney is going to be given to hair itself, and then I don't think that it's something like a anonymous sperm donor. We can compare.
Yeah.
We don't tell the recipient that whose sperm it is. I can compare it with that. But in this particular case, ma'am, the donor is agreeing only because you are assuring him that the kidney
If they ask you, but if they ask you that, you have to answer, and you have to tell them what kind of patients you have in your waiting list. Of course, you can say, look, we have, 125 people waiting for a kidney in this center, and then this organ will go to the one that might. You have to talk, and you have to explain them and answer their questions, but without personalizing it.
Right, I agree.
Yes? Okay, so if you all agree, now we are going to move to the workshops, okay? So make sure all of you have your IDs, your new IDs that are here on the table. So you will be distributed in colors, so please, the ones that do not have the ID should go here, for instance. You have to pick one. And then outside, yes, then Loli will explain you what to do.
Hi everyone. Good morning.
Do we have chitras in here?
So please, the ones that you don't have, pick up your ID, your group ID, and also sign the list of attendance for today. Please, this is very important for us. Yeah, and you will see that we have the 4 workshops in this corridor. We will distribute you, okay?
Kundan.
से सुबह करेंगे तो रात ही प्रोग्राम करेंगे
जितेंद्र ऋषिकेश
कैसे हुआ? ये बड़े पेशेंट कैसे हुआ?